We'll be starting off on page 266, just for continuity. We'll pick up on the paragraph just before that on page 265. Unresponsive patients. With an unresponsive patient or a patient with a decreased LOC, you should immediately assess the patency of the airway. Unresponsive patients should be considered to have experienced a traumatic event. If there is a potential for trauma, use the modified jaw thrust technique to open the airway. If it can be confirmed that the patient did not experience a traumatic event, use the head tilt chin lift technique to open and maintain a patent airway. Both of these techniques are described in Chapter 9, Airway Management. Another cause of airway obstruction in an unconscious patient could be relaxation of the tongue muscles, allowing the tongue to fall to the back of the throat. Dentures, blood clots, vomitus, mucus, food, and other foreign objects may also create an obstruction. If the airway is clear, you can continue your assessment. Signs of airway obstruction in an unconscious patient include the following: obvious trauma, blood, or other obstruction, noisy breathing such as snoring, bubbling, gurgling, crowing, or other abnormal sounds. Normal breathing is quiet. Extremely shallow or absent breathing. Airway obstructions may impair the breathing. If any of the aforementioned conditions exist, the airway is considered not patent and you should open the airway using the appropriate method, the head tilt chin lift or jaw thrust maneuver. Suction as necessary and use an airway adjunct as necessary. The body will not be supplied the necessary oxygen needed to survive if the airway is not managed quickly and efficiently. Remember that airway positioning depends on the age and size of your patient. For trauma patients or patients with an unknown illness, you must manually stabilize the cervical spine while using the jaw thrust maneuver to open the airway. Assess breathing. A patient's breathing status is directly related to the adequacy of his or her airway. Once you have made sure the patient's airway is open, make sure the patient's breathing is present and adequate. A patient who is breathing without assistance is said to have spontaneous respirations or spontaneous breathing. Each complete breath includes two distinct phases: inspiration and expiration. During inspiration or inhalation, that's inspiration or inhalation, the diaphragm and intercostal muscles contract and the chest rises up and out, drawing oxygenated air into the lungs. During expiration or exhalation, that's During expiration, the muscles relax and the chest returns to its original position, releasing air with an increased carbon dioxide level out of the lungs. Inhalation and exhalation times occur in a 1:3 ratio. The active inhalation phase lasts 1/3 the amount of time or the passive exhalation phase. Let me back up and say that again. Inhalation and exhalation times occur in a 1:3 ratio. The active inhalation phase lasts 1/3 the amount of time of the passive exhalation phase. Breathing is a continuous process in which each breath regularly flows the last with no notable interruption. Pardon me on that, I mispronounced something. Breathing is a continuous process in which each breath regularly follows the last with no notable interruption. Breathing is normally a spontaneous, automatic process that occurs without conscious thought, visible effort, marked sounds, or pain. You will assess breathing by watching the patient's chest rise and fall, feeling for air through the mouth and nose during exhalation, and listening to breath sounds. With a stethoscope over each lung, chest rise and breath sounds should be equal on both sides of the chest. When assessing breathing, you must obtain the following information: respiratory rate, rhythm, is it regular or irregular, quality, character of breathing, and depth of breathing. As you assess the patient's breathing, you should ask yourself the following questions. Does the patient appear to be choking? Is the respiratory rate too fast or too slow? Are the patient's respirations shallow or deep? Is the patient cyanotic or blue in color? Do you hear abnormal sounds when listening to the lungs? Is the patient moving air into and out of the lungs on both sides? Oxygen should always be administered to patients who are having difficulty breathing, but it may also be provided to patients who are breathing adequately. Positive pressure ventilation should be performed for patients who are apneic, or whose breathing is too slow or too shallow. If a patient seems to develop difficulty breathing after your primary assessment, you should immediately reevaluate the airway. If the airway is open and breathing is present and adequate, you should consider administering supplemental oxygen. If breathing is present and inadequate, the normal rate is 12 to 20 breaths a minute in adults. Because respirations are too fast, generally more than 20 breaths a minute, too shallow, generally fewer than 12 breaths a minute, you should administer supplemental oxygen when respirations exceed 24 or are fewer than 8. You should consider providing positive pressure ventilations with an airway adjunct. Remember that air exchange is the critical issue, not the number of breaths. Air exchange is the critical issue, not the number of breaths. Respiratory rate. A normal respiratory rate varies widely in adults, ranging from 12 to 20 breaths a minute. Children breathe at even faster rates. With practice, you'll be able to estimate the rate and note whether it is too fast or too slow. At times, it may be important to actually count the number of respirations during your primary assessment. Respirations are determined by counting the number of breaths in a 30-second period and multiplying by 2. Respirations are determined by counting the number of breaths in a 30-second period and multiplying by 2. The result equals the number of breaths per minute. For accuracy, you should count each breath at the same point in its cycle. This is most easily done by counting each peak chest rise. Although you can see peak chest rise, it is easier to place your hand on the patient's chest and feel it. However, be aware that a conscious patient who knows that you are evaluating his or her breathing will often override the automatic rate and depth by breathing more slowly and deeply. To prevent this from happening, you should check respirations in a conscious, alert patient without making the patient aware of what you are evaluating. This can be easily done by first taking a radial pulse, and then, without releasing the wrist or otherwise suggesting a change, counting the chest rise that you see or feel as the patient's forearm rises and falls with the movement of the chest. See Figure 8.11. If the patient coughs, yawns, sighs, or talks during the 30-second period, you should wait a few seconds and start again. See Table 8.2. Table 8.2 shows the normal range of respiratory rates of patients who are at rest. Respiratory rhythm. While counting the patient's respirations, also note the rhythm. If the time from one peak chest rise to the next is fairly consistent, respirations are considered regular. If respirations vary or change frequently, they are considered irregular. When you document the vital signs, be sure to note whether the patient's respirations were regular or irregular. Quality of breathing. It may be helpful to listen to breath sounds on each side of your patient's chest early in the primary assessment. This can help identify the quality of air movement in both lungs. Decreased or absent breath sounds on one side of the chest and decreased movement in the rise and fall on one side indicate inadequate breathing. Normal breathing is silent or in a very quiet environment accompanied only by the sounds of air movement at the mouth and nose. Through a stethoscope, normal breath sounds include only the sound of air movement through the bronchi accompanied by a soft, low-pitched murmur. Breathing accompanied by other sounds indicates a significant respiratory problem. When the upper airway has a mild obstruction by a foreign body or swelling, you may hear stridor, a harsh, high-pitched crowing sound. If you can hear bubbling or gurgling, the patient probably has fluid in the airway. You should immediately suction the patient to avoid aspiration of fluid into the lungs. You may hear other sounds like wheezes or snoring, or a musical sound indicative of a mild lower airway obstruction. A mild airway obstruction is usually a result of the tongue blocking the airway. The presence of any of these indicates that a serious respiratory problem exists. With a severe airway obstruction, the patient will not be able to move and air will no longer be able to cough or talk. Sounds are caused by air moving through small spaces or fluid. If you hear no sounds, the patient may be moving no air. A patient who coughs up thick, yellowish, or greenish sputum, that's matter from the lungs, liquid from the lungs, most likely has an advanced respiratory infection. A patient with a chest injury may cough up blood or frothy, whitish, or pinkish, foam-like sputum. A patient with congestive heart failure may also cough up frothy sputum. The presence of either substance, regardless of its cause, indicates that an urgent, potentially critical cardiovascular and respiratory problem exists. The patient's condition may deteriorate rapidly to a point in which the patient can no longer breathe. Page 268. The following describes how and where to listen to assess breathing. First, remember that you can almost always hear a patient's breath sounds better from the patient's back. Therefore, if the patient's back is accessible, listen. That's auscultation. So listen or auscultate there. If you have immobilized the patient, or if the patient is in supine position, listen from the front and sides. See figure 812. Auscultate over the upper lungs or the apices, the lower lungs or bases, and over the major airways, mid-clavicular and mid-axillary lines. Lift the clothing or slide the stethoscope under the clothing. When you listen over clothing, you will primarily hear the sound of the stethoscope sliding over the fabric because breath sounds are muted by clothing. Place the diaphragm of the stethoscope firmly against the skin to hear the breath sounds. What are you listening for? You may be able to identify one of the following sounds. Normal breath sounds. These are clear and quiet during inspiration and expiration. Wheezing breath sound. These suggest an obstruction of the lower airway. Wheezing is a high-pitched whistling sound that is most prominent on expiration. Rales. Wet breath sounds may indicate cardiac failure. A moist crackling, usually on both inspiration and expiration, also called crackles. Rhonchi. Congested breath sounds may suggest the presence of mucus in the lungs. Expect to hear low-pitched, noisy sounds that are most prominent on expiration. The patient often reports a productive cough associated with these sounds. Stridor. This is often heard without a stethoscope and may indicate that the patient has an airway obstruction in the neck or upper part of the chest. Expect to hear a brassy crowing sound that is most prominent on inspiration. You can determine the quality or character of respirations as you are counting the number of respirations. See Table 8.3. Table 8.3 shows 4 ways in which the quality or character can be described. Use your sense of hearing to listen for breath sounds, or use the preferred method of auscultation, listening with a stethoscope. Note any adventitious lung sounds and treat the patient accordingly. Depth of breathing. The amount of air that the patient is exchanging depends on the rate and the tidal volume. Tidal volume is a measure of the depth of breathing and is the amount of air in millimeters that is moved into or out of the lungs during one breath. The depth of the breath determines whether the tidal volume is normal, less than normal, or more than normal. Observe how much effort is required for the patient to breathe. Normal respirations are not usually shallow or excessively deep. Shallow respirations can be identified by little movement of the chest wall, reduced tidal volume, or poor chest excursion. Deep respirations cause a significant rise and fall of the chest. You should document when the patient's respirations are shallow or deep. However, you do not have to record a normal depth of breathing. The presence of retractions, indentation above the clavicles and in the spaces between the ribs, or the use of accessory muscles of respiration is a sign of inadequate breathing. Accessory muscles include the neck muscles, sternocleidomastoid, the chest, pectoralis major muscles. Breathing in pediatric patients indicate inadequate breathing. A patient who can speak only 2 or 3 words without pausing to take a breath A condition known as 2 to 3 word dyspnea has a serious breathing problem. Normal breathing is an effortless process that does not affect a patient's speech, posture, or positioning. Speech is a good indicator of whether a conscious patient is having difficulty breathing. A patient who can speak smoothly without unusual extra pauses is breathing normally. However, a patient who can speak only one word at a time, or must stop every 2 or 3 words to catch his or her breath, is having significant difficulty in breathing. Patients who are having marked difficulty breathing will instinctively assume a posture in which it is easier for them to breathe. There are 2 common postures that indicate the patient is trying to increase airflow. The first position is called the tripod position. In this position, a patient is sitting and leaning forward on outstretched arms with the head and chin thrust slightly forward. Significant conscious effort is required for breathing. The second position is most commonly seen in children, the sniffing position. The patient sits upright with the head and chin thrust slightly forward, and the patient appears to be sniffing. Figure 8.13. Breathing that becomes progressively more difficult requires progressively more effort. When you can see that effort, the patient's breathing is described as labored breathing. Initially, labored breathing is characterized by the patient's position, concentration on breathing, and the increased effort and depth of each breath. As breathing becomes more labored, accessory muscles in the chest and neck are used, and the patient may make grunting sounds with each breath. In infants and small children, nasal flaring and supraclavicular and intercostal retractions are commonly associated with labored breathing. Sometimes the patient may be gasping. Infants and small children may have labored breathing for a sustained period, will then often become exhausted, and finally will no longer have the strength to maintain the necessary energy to breathe. In infants and small children, cardiac arrest is generally caused by respiratory arrest. Respiratory distress occurs when a person, particularly a child, has difficulty breathing. Therefore, the work of breathing is increased. Typically, a person in respiratory distress presents with an increase in respiratory effort and rate. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meet the oxygen demands of the body. Respiratory arrest is the ultimate result of respiratory failure if it is not corrected. Table 8.4. Going on to page 270. Assess circulation. Assessing circulation helps you to evaluate how well blood is circulating to the major organs, including the brain, lungs, heart, kidneys, and the rest of the body. A variety of problems can impair circulation, including blood loss, shock, and conditions that affect the heart and major blood vessels. Circulation is evaluated by assessing the pulse rate, pulse quality, and pulse rhythm. You will also need to identify external bleeding and evaluate the skin. Assess the pulse. With each heartbeat, the ventricles contract, forcefully ejecting blood from the heart and propelling it into the arteries, often referred to as a heartbeat. The pulse is the pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. The pulse is most easily felt at a pulse point where the major artery lies near the surface and can be pressed gently against the bone or solid organ. Your first consideration when taking a pulse is to determine whether the patient has a pulse or is pulseless. To determine if a pulse is present, you will need to palpate, feel for the pulse. Hold together your index and middle fingers and place their tips over a pulse point, pressing gently against the artery until you feel intermittent pulsations. In responsive patients who are older than 1 year, you should palpate the radial pulse at the wrist. That's responsive patients who are over 1 year. Look at figure 8.14a. That is a radial pulse. In unresponsive patients older than 1 year, you should palpate the carotid pulse in the neck. Figure 8.14b. When palpating the carotid pulse, you should place the fingertips of your index and middle fingers along the carotid artery in the groove between the trachea and the neck muscle. Palpate the carotid pulse on the same side of the patient that you are on. Palpating on the opposite side of the patient may lead to undue pressure on the neck that may compromise respirations. Use caution when palpating the carotid pulse in a responsive patient, especially in older patients. Only gentle pressure on one side of the neck should be used. Never press on the carotid arteries on both sides of the neck at the same time. Doing so can reduce circulation to the brain. Sometimes you may have to slide your fingertips a little to each side and press again until you feel a pulse. When palpating a pulse, do not allow your thumb to touch the patient. If you do so, you may mistake the strong pulsating circulation in your thumb for the patient's pulse. Palpate the brachial pulse located in the medial area inside of the upper arm. Children younger than 1 year need a brachial pulse check. See figure 815. That is a brachial pulse. With the infant lying supine, you can access the brachial pulse by elevating the arm over the infant's head. Because most infants have chubby arms, you need to press your adjacent fingertip firmly along the brachial artery, which lies parallel to the long axis of the upper arm, to be able to palpate the pulse. If you cannot palpate a pulse in an unresponsive patient, begin CPR. If an AED is available, attach it and follow the voice prompts, following your local protocol. An AED is indicated for use on patients who have been assessed to be unresponsive, not breathing, and pulseless. An AED with special pediatric pads and a dose attenuating system should be used on pediatric patients older than 1 year. If these are not available, an adult AED should be used. In infants 1 month to 1 year, it is preferable to perform manual defibrillation or use a dose attenuating system. If these are not available, an adult AED should be used. More information about this available in Chapter 11, BLS resuscitation. If the patient has a pulse but is not breathing, provide ventilations at a rate of at least 10 breaths a minute for adults and at least 12 breaths a minute for an infant or a child. Continue to monitor the pulse to evaluate the effectiveness of your ventilations. If at any time the pulse is lost, start CPR and apply the AED, if indicated. The apparent absence of a palpable pulse in a responsive patient is not caused by cardiac arrest. Therefore, never begin CPR or use an AED on a responsive patient. That concludes this video. We've ended on page 270. At least stand up, go use the bathroom, and take a short break. When you get back, go over and look at the tables that we went over and the illustrations and graphics. And we'll pick up on the next video.